I want to thank Senator Carper for his focus in this regard. His example has made me go to the gym more and order egg beaters when I head for breakfast. So I thank you all for your testimony. Mr. Diaz, in your testimony, you highlight the important issue of increasing coordination and integration as a means to improve care and reduce unnecessary costs, something that we clearly want to achieve. Kindred's in a unique position to provide this high level of coordination as the operator of so many post-acute facilities. However, that can be difficult when those post-acute care sites aren't under one roof. In New Jersey, to address this issue, healthcare facilities, home care providers, and other stakeholders worked with state officials to create and implement what we call a mandatory universal transfer form. And the use of this form will, we believe, ensure that providers across the continuum of care have the access to patient history and information that will help improve care. So my question is, do you see that as a way to more effectively and accurately coordinate care for patients transferring into post-acute settings? And do you think something like a universal transfer form can be an effective tool to improve provider coordination?
I do, and whether it's in the ACO examples that we've talked about or other collaborations, which, we talked about a lot of capabilities, and I mentioned building trust, breaking down silos, things like IT to enable that is critical. And in each community, there's going to be a role for large integrated providers and individual providers. I think what it's going to require is that these networks, as we set up, people have to deliver on the value proposition, whether they're large or small, and so we have to allow for that, and people have to come at it from a collaborative perspective. I think the challenge is if we continue to approach things and sort of I win, you lose, we're never going to get anywhere, and that's going to require everyone giving a little bit in terms of breaking down these silos that we're in.
And I would assume that that sharing of information at the end of the day is critical, one, for the patient, and two, also for savings.
Without question. As you've heard today, and we've seen examples in our pilots, there's just tremendous patient opportunities and tremendous opportunities to reduce costs when we can give clinicians information to manage patients over an episode as opposed to whether they're in the short-term acute care hospital and align incentives around that, so has been spoken to.
And finally, I know that earlier, and you mentioned in your testimony, legislation that Mr. Nelson and Mr. Roberts are sponsoring, that I'm co-sponsoring with reference to long-term care hospital improvements, which outlines a specific criteria to better identify long-term care hospitals and their role within the continuum of care. Why is such specific criteria needed, and what would having such criteria in place actually accomplish?
Well, long-term acute care hospitals, like inpatient rehab hospitals, like skilled nursing facilities, play a unique role in the delivery system. Right now, there is a lack of regulatory clarity there. And I think what that would do, what the criteria would do, would enable not only public payers, but the private payers here to all of us understand better what that role is, what the outcomes that can be generated, and what the costs are. And I think that just enables us to be more efficient in getting patients to the most clinically appropriate setting as quickly as possible. And long-term acute care hospitals don't have that clarity in the way that other sectors do today.
Mm-hmm. Thank you.